Let's begin. I see there's already a handful of attendees with us. Welcome, everyone. Welcome to week 3 of the Co-Design Spotlight series. I will now open the webinar for this week. So for those of you who are new to the Spotlight series and to Health Translation SA, I am Agustina Gancia. I lead the capacity building portfolio at HTSA, and I am your host for the Spotlight series during these 4 weeks where we talk about co-design. So welcome. Before we begin, I would just like to acknowledge the Kaurna people as the traditional custodians of the Adelaide region. We recognize the Kaurna people's cultural, spiritual, physical, and emotional connection with their land. We honor and pay respects to Kaurna elders, both past and present, and all generations of Kaurna people now and into the future. So what is the Spotlight series? A quick run through for those who are joining us for the first time. It is an initiative launched by Health Translation SA in 2021 as a way to build knowledge and capacity in a range of essential research translation skills. We cover a different topic every time we host a series, and we host different activities during that series or during the duration of those 4 weeks. So we have webinars, we offer links to different trainings, we share online resources like articles or books, book chapters, interesting websites, and really delving into that specific topic. This series on co-design is our 8th series, and we've previously covered topics such as implementation science, establishing research policy partnerships, consumer and community involvement, the MRFF, health economics, a whole range of topics. And if you want to learn more, everything is hosted on the HTSA website, and you can even go to the previous webinars and have a listen to those. Who's HTSA? Just quickly, we're an NHMRC accredited health research translation center, and we offer a collaborative and cross-sectoral approach to research and the translation pathway from evidence into patient care. And essentially, we just seek to connect health researchers and health services with the right stakeholders just to accelerate the implementation of research discoveries. We have 11 partners that span the whole of the health system, delivery in South Australia. So really, we try to connect people together. And our vision, like I mentioned, is to accelerate the translation of research findings into action as quickly as possible to ensure that scientific evidence is actually used and can positively impact on health of South Australians. And we do this in many ways. We connect, like I mentioned, through our partner organizations. We connect researchers to different stakeholders, health services, policy, and host education and training initiatives. And the Spotlight series falls in that category. So today we have 3 excellent and experienced presenters. We will have an initial presentation from Dr. Tina Brodie from the Wardley-Paringa Aboriginal Health Equity Group here at SAHMRI. Then we'll have a presentation from Dr. Katharine Brown and Karrina DeMassi from Telethon Kids Institute. And Tina will initially provide us with a bit of background on doing research with First Nations people and what are the core principles of co-design, and as well as an example of a project that she's working on. Then Katharine and Karrina will present their team's study co-designing a model of care with Aboriginal women. And their session is titled Conceptualizing Co-Design to Develop a Model of Care with Aboriginal Women. So I'll quickly introduce all 3 of our speakers, and then I'll hand it over to Tina. But before I hand it over to our speakers, I would just like to say, we'll listen to the 2 presentations, and if anyone has any questions or comments, please feel free to enter them in the Q&A section of Zoom. Otherwise, we can, and then I'll ask those questions at the end of the 2 presentations. So, introducing Tina. She's an Aboriginal woman with connections to Yara Warka and Yandru Wanda. I'm so sorry if I didn't pronounce that well. Tina is a research fellow in Wadley Paringa Aboriginal Health Equity at SAHMRI and the University of Adelaide in the Faculty of Health and Medical Sciences. She holds a Bachelor of Social Work, a first-class honors, a graduate certificate in counseling and psychotherapy, and a PhD. She has over 15 years of experience in Aboriginal health and well-being in research, clinical, project, and leadership roles. Her research explores Aboriginal and Torres Strait Islander social and emotional well-being, specifically the social determinants of health. She has expertise in Indigenous methodologies and engaging Aboriginal and Torres Strait Islander people and communities in research. Then we'll hear from Karrina and Katharine. Karrina has recently moved to Ghana country after living on Larakia land for 24 years to be closer to family, after growing up in Broken Hill and on the Barca. Professionally, she's a registered nurse and a midwife with over 35 years experience in Aboriginal health, including an extensive period working in Aboriginal community-controlled health sector, ranging from Aboriginal education, teaching Aboriginal health practitioners and registered nurses, managing chronic disease teams at Danila Dilba Health Service, the Heart Foundation, the RFDS, and most recently as a senior public health policy officer within Aboriginal Medical Services, NT. She's studied public health, sexual health, child health, clinical nursing, and vocational training postgrad. Finally, Katharine is a postdoctoral research fellow in the Indigenous Cardiovascular Research Program at Telethon Kids. She's a non-Indigenous woman living and working on Ghana country. Her research draws on her experiences in advocacy, policy, and translational research to respond to disparities in cardiovascular health and disease experienced by Aboriginal and Torres Strait Islander communities. So I will hand it over to Tina now. Welcome. I'll stop sharing. Over to you, Tina.
Thank you. I'll just share my screen. Get started. Okay, thank you. Looking forward to chatting with you all today. So we'll just get started. Just briefly, I want to acknowledge that I also acknowledge that we're meeting on the lands of the Kaurna people, and we pay our respects to their ongoing connection to this place and recognise that sovereignty was never ceded. Just like to start by a little bit of positionality. It's a sort of cultural protocol to let you know a little bit about me and who I am. So you heard my bio, but also my connections. You did a really good job at Yandrawanda and Yarawaka, which is up near Inaminka, in sort of around the top corner of South Australia, top sort of northeast. I think I got my geography correct. I'm a mum. I have 2 young children, primary school aged. We live on the beautiful, that's the photo you can see there, is Ngakipari. Means Women's River down south. We live down south of Adelaide. And, you know, I'm a proud dog mum as well. So I work in Wadley Paringa Aboriginal Health Equity. Wadley Paringa was the name given to our research group by the Kaurna Language Committee. Wadley Paringa is a Kaurna term, and Wadley refers to house. Paringa refers to river place, therefore its meaning is house by the river. It's also the term used to describe the reflection of the Milky Way in the River Torrens alongside where SAHMRI is located. And so in Wadley Paringa, we aim to establish nation-leading research, and we have focus across all sorts of areas from like that, health and well-being more broadly, social determinants of health, mental health, chronic disease, health systems, capacity development. So we have a really large research program here in Wadley Paringa. And so in Wadley Paringa, all of our work is governed by the Aboriginal Health Research Accord. And so this document contains a range of principles to guide doing research the right way. And so these priorities came about from literature search and community consultation, and all of the universities here in South Australia are signatory to this. And so I guess to summarise, you know, it's about, so the principles are things like priorities. And so all of the work that, all research with Aboriginal and Torres Strait Islander communities should be a priority of the community. It's got things about communication and respect, how we engage with Aboriginal and Torres Strait Islander communities, always willing to listen, the involvement of Aboriginal people and organisations within research is essential, especially obviously when it is about or for them. a focus on knowledge translation. And so obviously that really aligns with Health Translation SA's agenda, is that all research with Aboriginal and Torres Strait Islander communities should focus on having an impact or a benefit to community. And so that's through knowledge translation, working in partnership, Aboriginal and Torres Strait Islander communities having control over research and data and outputs from research, ownership and reciprocity. So thinking about, again, what I said, there being a benefit to community and community gaining something from the research process. And so all of those principles really align in a sense with, I guess, co-design and why you would do it. I'm going to talk a little bit about, I guess, why we need things like the Accord and how important they are and why they shape things. So Aboriginal and Torres Strait Islander communities in Australia have experienced ongoing colonial violence. So since, I guess, the arrival of the First Fleet, communities have been disempowered and disenfranchised. And as a result of that, they experience greater health inequities and often poorer health outcomes. And while it's important not to focus only on the deficits, when we're talking about why we need to do research a certain way or the importance of that, we can't do that without drawing attention to harms that have been caused and how we got here. And so in talking about that as well, so reflecting on oppression, dispossession, and, you know, I think people think that, you know, that's something that happened and no longer happens. And so when it comes to ongoing colonial violence and racism, we know these are things that still occur in Australian society today. And that's not something that has, you know, a thing of the past. It's an active thing that we need to be working against. And when it comes to our research, we really need to be considering that. I was at a conference a couple of years ago now, or maybe it was last year, and Professor Lester Iribuna-Rigney was talking about how, as researchers, we need to take the temperature of the nation and speak back. And so what he meant by that is, as researchers, we should be mindful of the entire context, and in our research, we should be trying to address those things and sort of not just settling for status quo or, you know, staying in a safe zone. It's like we need to be challenging and always striving. And so in co-design or in working with Aboriginal and Torres Strait Islander communities, it's important to understand the broader context and then think about how that applies in our research work. And so one of the ways, particularly Aboriginal and Torres Strait Islander researchers do this, but also these methodologies are available for all people to use, is by using an Indigenous methodology. And so Indigenous methodologies are essentially the way we approach research. So things like all of those principles in the Accord, you know, they form an Indigenous methodology. How are we making sure that what we are doing is consistent with the ways of knowing, being and doing of the Aboriginal and Torres Strait Islander community? So what methods we're selecting, how we're choosing to answer our research question, how we're engaging with the community as part of that process, all form, you know, the methodology. And so when we think about Indigenous methodologies, these should really be aligned to things like the principles in the Accord, or best practice principles in Aboriginal and Torres Strait Islander research. And so one example that I thought we might go through a little bit today is of one of our projects called Tangawul Tuperku Kawandilla, which means strong community in the north. This name was given to us by Ghana Warrakarapinthi, and the aim of Tangawul Tuperku Kawandilla was, I guess, still is, we're still active in this project, to co-design, implement and evaluate multi-level strategies that tackle the social determinants of health and strengthen health and social service system responses to promote social and emotional wellbeing in Aboriginal and Torres Strait Islander peoples in Northern Adelaide. And so this project really sets out, you can see some, I guess, some key principles. You can see those in green around the outside. So to draw your attention first there, it's really about research and practice partnerships, Indigenous methodologies, the rapid translation of emerging evidence, and a complex systems approach. And so what this project aimed to do was, you know, understand what the need is and what we already know, come up with some strategies to address those needs, and some actions to meet those needs. And I guess the thing that's really of interest is that this entire process is informed by Aboriginal and Torres Strait, well, I guess informed isn't the right, it's governed by Aboriginal and Torres Strait Islander leadership. And so when we think about ways that co-design can come to life within a research project, one of the ways we enact that within this work is by having Aboriginal and Torres Strait Islander governance. And so this is from community members, key stakeholders across the service sector, the chief investigators and the associate and partner investigators that are on this project. And predominantly these are all Aboriginal and Torres Strait Islander people, bar a couple of our allies who work in this space. And so that maybe just before we go on, the Aboriginal Governance Panel, they meet regularly and they sort of guide and inform this work, and they were entirely a part of these next few slides that we're going to go through. So they informed how we went about all of this. So we set out to understand what the needs were and what we already know. And we did this by looking at community needs, service gaps and innovations, and, you know, interorganisational partnerships and things like that. And so, you know, one thing that we often do in Aboriginal and Torres Strait Islander health research to ensure the voice of community is heard and that things reflect their lived experience is we talk to community. So we yarned with 55 Aboriginal and Torres Strait Islander community members and service providers and 28 non-Indigenous service providers to identify community needs, service gaps, success stories and solutions that would strengthen the service system. And there's some examples up there, but they're probably, you know, that's more specific to the project. You can have a read through those if you're interested, but more wanting to share with you is the way we went about doing it. And so we talked to community, and a lot of the things that came out, which is, I guess, of interest is the importance of self-determination and practices which promote self-determination. So in thinking about Aboriginal and Torres Strait Islander research and engaging in co-design processes, essentially we should be aiming for Aboriginal and Torres Strait Islander people to be self-determining and to determining their own priorities and to determine the direction of the research. And so even, I guess, the findings within our findings always highlight the importance of self-determination. And, you know, when we analyse this data set, these things came across were people talking about individual practices which can enable self-determination, collective actions, and also organisational approaches which can promote self-determination. We then had to come up with some strategies to address the needs. So once we analysed the data and found out what the gaps were, we co-created strategies for systems change and implementation plans and evaluation frameworks with the Aboriginal Governance Panel. So we sat down together and we went through this complex wheel with all these sort of elements that had come out through after the yarning interviews. And we sat down with the Governance Panel and they really determined what areas, well, we looked at every single area and we came up with strategies in every single one of them. So we had conversations about them all, and then we had to prioritize some key kind of areas for this project to take some action on. So we're thinking about that transition from understanding the needs, working with community about how to respond to those needs, and coming up with the strategies and solutions and I guess the areas of priority. So I'm going to talk about just one of the implementation projects. So once we went through that process, then we went through, you know, we set up a range of sort of, we call them demonstration or implementation projects, which are going to advocate for system change. And these occur across different layers. So these are under each of these boxes, then there's some implementation projects. And we're going to chat to you a little bit more about just one of those. So that's probably all we would have time for. So Tangawilta Burka Cowandilla is working with Safe Haven, which is a mental health drop-in centre in Northern Adelaide. And so based on that sort of the Tangawilta co-design priorities, it was one of the areas that was identified was mental health support, identifying unmet needs and making service connections. And so this implementation project responds to that sort of co-design priority. And in order to respond to it, it includes establishing a partnership, so a collaborative partnership between the project, so Tanglewood to Burka Cowandilla, Sonda, who hosts Safe Haven, and the Northern Adelaide Local Health Network, Aboriginal Health, sort of Wadapur and Aboriginal Health. We have a partnership and, you know, really aligning. The reason for that to come to fruition is because there was alignment between all of us and all of the priorities and Tanglewood to Burka Cowandilla and the co-design priorities. So, you know, it was about finding the right fit to be able to maintain what the community needs and priorities were and implement those. So it'll be implemented within Safe Haven at Salisbury. A funded position will work with Aboriginal and Torres Strait, 2 funded positions will work with Aboriginal and Torres Strait Islander people as part of that. And so the long-term goals are really around strengthening social and emotional well-being, workforce, and advocacy for some of the broader community design priorities. So one of the larger priorities that came out was, you know, a community hub. And so what happened as part of this project is some of those priorities, I guess, you know, like that, if you're going to talk to community, you want to genuinely ask and you need to be prepared to actually genuinely do something about it. And so when it came to something like a community hub, and that came up time and time again as a key priority from the Yarns and also from the Aboriginal Governance Panel. And so establishing a community hub is not necessarily something that's within the scope of a sort of a 4 to 5 year funded research project. It requires sort of enabling infrastructure from across the system, so the health system, you know, getting in touch with policymakers, engaging in all sorts of different ways to then bring that to fruition. So we won't deliver on a community hub because that's not within scope, but we don't lose focus on what the community said was important and what the priorities of the community are. So even if that's not responded to as part of this, it sort of stays on an agenda and continues to be progressed. And so that in that thread, the way that we are able to influence and have translation and impact is in this project, we produce 2 reports. So to keep the community informed and connected and as part of the process, not just, you know, the governance structure, but the wider community, we produced a community report. And so you can check that. That's the orange one. You can have a look at it online if you're interested. About it. It goes into a little depth about, again, the co-design findings, what we found, how we went about that, and, you know, is pitched in a way that people within the community could have a read of that and understand what the priorities were from people that were spoken to in Northern Adelaide. And then you'll see the blue flyer. This is what I was talking about community hubs, about the importance of those. And you know, this is a more of an evidence or policy brief. So whilst we're not able to create a community hub as much as we wish we had the resources to do so, you know, we produce this brief to advocate, to share, to continue those conversations and make sure they aren't lost. And so this is really, I guess, a way of summarising one of the community priorities that had come out throughout the co-design process. And so I don't know how I went for time. I might have zoomed through maybe too fast, but I'd really appreciate, obviously, if anyone has any questions or would like to hear anything further, please chuck them in the Q&A. Definitely happy to answer any questions or have a yarn at the end. And yeah, you can find more about me on SAHMRI's website or listen to my podcast, which I also talk about some of these things as well. So, me.
Thanks, Tina. That was such a great presentation. Before, like I said, we'll be taking actual questions at the end of the session, but someone did ask a question about if the slides will be available at the end of the session. If there is, you know, interest from the audience, and if the presenters are happy to share their slides, I'd be happy to share that as a resource at the end of the month, as part of our content summary of co-design. So if you're happy to share your slides, I'd be very happy to put that on the HTSA website along with the other resources.
Yep.
I would now like to hand it over to Karrina and Katharine for their presentation.
Thank you, Dr. Tina. and congratulations. And thank you so much for inviting us to be part of the Spotlight series. I have had the privilege of listening to the other sessions, which have been really very, very interesting. And thanks again for the opportunity. Our example today is in terms of thinking about co-designing with Aboriginal and Torres Strait Islander women, and thinking about how we might position ourselves in terms of co-design, incorporating all of those principles that Tina has spoken about, and we will touch on some of them also. Thanks, Katharine. And so we would like to also acknowledge the Kaurna people and the lands and waters in which the Institute is located here in South Australia, and we seek their wisdom in our work to improve the health and development of all families and children. I'd also like to acknowledge all of the Aboriginal and Torres Strait Islander people joining us today and the lands in which they are located. Just to position myself, I am a Barkindji woman and have been living on Larrakia land for many, many years after growing up on Barkindji country. I've had the privilege of being involved in several key research projects, which I feel has been well positioned in terms of co-design and been centred around self-determination after working in Aboriginal community control for many, many years. I've had the privilege of being part of a career pathways report with the HTSA Institute, and also have been leading a project with the Central Australian Academic Health Science Network, which is all around translational work for Aboriginal community controlled health services, in which they set the priorities and inform us in terms of directions and what's important in terms of their work. Sorry, thanks, Kat. So our work today, so our particular project, so I now have the privilege of working for Telethon Kids Institute. Our particular project is around building the knowledge and well-being as expressed by Aboriginal women that are experiencing or living with or have previously lived with complex cardiometabolic conditions in pregnancy. We have a fairly firm understanding in terms of where we think that we can work with women in terms of their lived experience in informing us in terms of priorities. So we see here from the different stages. So the stages in the blue in terms of Aboriginal women designing that model of care and setting a priority. So in terms of Aboriginal health, we're seeking the expertise in terms of experience from Aboriginal health staff that have been working with women and families, as well as women who have experienced those complex conditions themselves in terms of lived experience. Collectively working with those groups and key people in terms of developing and evaluating tools as identified within a model and mapping those respective components that might work and inform and support services and the respective health sectors. And then, of course, developing and implementing strategies that integrate some of these key strengths and or key challenges. So we want to focus in terms of strengths and enablers within the system and how we might be able to support those as part of our work. You can see in our broader model, it's all encompassing and thinking about, that's all right, thanks, Kat. In terms of thinking about the journey. So we understand that, and as a midwife also, that's probably been part of my thinking in terms of pregnancy is a journey, and it doesn't just stop. There is points across that journey that we are interested in terms of hearing the voice of lived experience in terms of what's happening, pre-pregnancy, what's happening in terms of the infant well-being, that long-term maternal health, and what's happened in terms of those points of care and those pathways in terms of the journey, the pregnancy journey. We're also thinking about, as we know, Aboriginal ways of knowing, being and doing aren't just in terms of my physical health. We want to think more broadly in terms of how can we support and listen to what's important in terms of an enabler, in terms of cultural care, emotional, physical and social well-being. So that's a very important aspect in terms of when we're thinking about co-design, that we're not coming in with a preconceived idea that pregnancy is just about some physical journey or physical well-being. Thanks, Kat. We have many partners. We have very strong Aboriginal governance and leadership as part of our project. And these are just some of our key partners in the project, including the Aboriginal Communities and Families Research Alliance, SAHMRI, Aboriginal Health Equity, Telethon Kids, obviously, and ANU and the Aboriginal Health Council of South Australia. In the broader aspect of this journey, we have the Country PHN, Diabetes SA, the Heart Foundation, and all of our local health networks and the Aboriginal community controlled sector are very important as part of our capturing a voice and partnerships as part of the project. Sorry, Kat, thank you. So thinking about what co-design really is, and what I found interesting in the other webinars is actually starting to define what co-design really looked like. And in terms of where we sit and we are positioned in terms of the model of care, we have some really great leadership in terms of an Aboriginal Kaurna woman, Dana Sheen, who'll be leading part of our work and is part of our research team also, which I wish to acknowledge. Dana is going to be critical in this space, and thinking about what really is a model of care and what are we co-designing. So it's not just about that model of care, but what are those key strengths, where we will sit in terms of identifying priorities, going back to the women in part of this journey. So it's not just about engagement in the initial stages of let's come together, have a yarn, think about what's happening as part of your journey and what the model might look like, but how we might inform the health system, how we will be evaluating the model and implementing key aspects of the model. And what we're not co-designing is the actual, we're not just there to say, here we go, tick a box in terms of stakeholders, in terms of our the one-off, bringing women together as part of that model of care discussions. Thanks, Kat. So we have some workshops, yarning opportunities where as I've discussed, that we'll be bringing our key participants together. So mainly around lived experience and Aboriginal health staff that have been working in the system, not just clinicians. We have interest from a whole range of different people that have been working both in children's services and people on the ground, and regional and remote stories also, which we think is really important. we'll be thinking about sharing those stories, identifying those key principles as part of our model of care, what those respective components will look like as part of the journey, the pregnancy journey. It doesn't just sort of, you know, we understand that a pregnancy journey doesn't happen just, you know, as you're pregnant. There's a whole range of work that happens in the postpartum area as well. And what a prototype might look like. So it was interesting to listen to the webinar around co-designing prototyping. So what does that look like? So it is about the journey and hearing and listening and bringing people along with the journey as we're undertaking the project. And we want to review and refine that model. So sharing stories, we're thinking about the health journey mapping tool and the framework used by Dr. Janet Kelly, appropriate recognition as part of people's contribution and ongoing involvement. So again, that will be something that we put to the women that are participating as part of the project, how they would like to be involved, what aspects they would like, who would they like us to share this story with, who else we can go to in terms of refining that model. Thanks, Kat. And what I think is interesting, and we'll talk a little bit more as part of our presentation, is that technically co-design is really framed around a Western methodology, because in fact what it implies is that Aboriginal people don't have the initial power to bring people into where we're thinking about this in terms of a co-design as a non-Aboriginal person coming to an Aboriginal person. And I think we need to be thinking about that, is that it needs to be Aboriginal led. The power and the relationships and the collective sit and are positioned in terms of Indigenous methodologies and leadership. So it's not about non-Aboriginal people coming to us and saying, will you be part of a project? Give me your expertise and then I'll go off and think about writing that up. So this was something that was presented to us from our Maori colleagues, is co-design the right terminology? What it implies is that there's an equal power relationship. Anyway, that's food for thought. Next. I just want to put that to people to say, we're not always co-designing, so we actually need to shift that to the Indigenous led. Kat is going to talk about some of the best practice principles now. Thank you.
My apologies, I just had to find out how to unmute myself there. So before we talk a little bit more about our project and how we're doing it, and I think, you know, both Karrina and I are really clear that we are at the start of this project. It's early days and we're just about to do our co-design. And so we're talking about what we will be doing, not necessarily what we have done. And we put a big disclaimer on that. But last year there was a fantastic paper that was published by Anderson and others, which sets out 6 key principles and gives guidance around best practice for doing co-design with Aboriginal and Torres Strait Islander communities here in Australia. And so the rest of our present is really just reflecting on some of the ways that we're thinking about these key principles and how we're trying to respond and address them within our project. So the principles are First Nations leadership, very much authentic and appropriate First Nations leadership embedded across co-design and leadership across the life of the project, ensuring that there's a culturally grounded approach and that this recognises the strength and diversity of First Nations cultures, and that it's a continuous process of striving for cultural competency and safety and of self-reflection, particularly by non-Indigenous researchers working in this space. Respect, which is very much around recognising the expertise and experience and time of people and organisations, and ensuring that that is respected and recompensed and recognised appropriately and in a timely manner across the life of the project. And it also, that principle of respect also focuses very much on the need to ensure that there's flexibility and appropriate ways of engagement with communities and with individuals. The next principle that they talk about is benefit to community. That one is quite clear, that we must be serving communities above all else in the way that we do our work. And that has to start at conceptualization and go through design, process, and outcomes. And it has to deliver tangible, meaningful benefits to community. Inclusive partnerships, ensuring that we're fostering and maintaining equitable and collaborative relationships across the life of our co-design work. And then finally, transparency and evaluation. And this is ensuring that there's transparency in all aspects of the co-design project, and ensuring that there's accountability to communities, to individuals, and to leaders, and that is formalised and embedded into the way that you do work. So these are national principles around co-design. I think, you know, the work that Tina talked about, and particularly the principles of the Accord that we have here in South Australia, they're very much talking about the same things, and there isn't any conflict between them, which is really important. And how are we striving to do this within this project, where we're responding to the heart and diabetes, women who have heart and diabetes complications in pregnancy here in SA? The first principle is First Nations leadership. We have established a research team which has very strong Aboriginal women's leadership. This is very much a women's space and a women's health priority, and we recognise that, and we recognise the need to ensure that there are safe gendered spaces within this project. Within a really strong investigator team, we then have also developed a really strong governance structure across our project, and so we have a Aboriginal Women's Governance Group, and their role is really to ensure that we are accountable to community, to women, and to services, and that we are doing what we said we would do. So we have two strong co-chairs in that, and I'll name them later. But that group is also ensuring that we have the protocols and principles in place to ensure that we're meeting some of those principles that we talk about later. So ensuring that we are delivering benefit to community, that we are having translatable outcomes that are coming out of this, and ensuring that we are appropriately acknowledging and recompensing all of the women who are involved in our work. And we have really strong leadership within community control. So we're having really good engagement across community controlled health services as well. I think one really nice example around strong leadership is when we started scoping up this project and the early conceptualisation. This project comes from many years of work and identified priorities, but we started talking around just the care after pregnancy, and the discussions that we had with Aboriginal women leaders across the state was that we had to not just focus on that after pregnancy story, but we had to do the whole journey of care. And so that's one example where from early conceptualisation of a project, we've actually reshaped and expanded our work. The next principle is around culturally grounded approach. And fundamentally, what we see at the core of this project is that women are leaders and nurturers and carers, and having complications in pregnancy and the long-term health effects of potentially those complications impacts on women's capacity to fulfil those roles within their community and within their family, and those leadership roles. And so that is the foundation of our narrative and where we start. And as Karrina spoke about, we are founded in an approach that is recognising not just physical well-being, but is a holistic approach to social, cultural and emotional well-being. And particularly what we see for women who have cardiometabolic complications in pregnancy is that all of the focus goes to their physical health around the diabetes or heart complication. And so they have these horrible journeys because it's not meeting their social, emotional and cultural well-being needs. And therefore it's a really difficult journey and has long-term impacts of that. And as Karrina mentioned, we're really focusing on ensuring that we have diversity in voices and experiences across different communities, across different age groups as well. And also we're building in the story of men as partners and fathers to make sure that we're not losing their voices. And again, that's something that's come through as part of our conceptualisation. The next principle is around respect. And the way that we're designing our co-design space is that we're ensuring that it's a Aboriginal women-led space. And I, as a non-Indigenous researcher, have actually said to Karrina and Dana that as we're in our co-design spaces, the women are coming together. If it's appropriate to boot out the two non-Indigenous staff on this, then I expect you to do it. If it's not appropriate for us to be in the room, then we shouldn't be in there. So ensuring that that is well recognised, that all of the women who are doing the co-design recognise that this is their space that they are controlling. We're using a yarning-centred approach, and we're focusing on really strong engagement right across community-controlled health services, recognising that they're embedded within community and reaching out through community control. And the other thing is that we have built in, and we built this into the funding, really respectful reimbursement for women and for health services, recognising their time and contribution and the knowledge that they bring into this. In terms of benefit to community, again, our focus is improving pathways of care. That is the focus of our project. And we're asking women as part of the co-design to say, what are the principles of provision of care, of knowledge and support that you think should be foundational to the way that health services and systems respond to your needs? Women are going to identify and prioritise actions as part of that development of the model. And so we'll ask them to say, okay, these are all the bits that we identified need to be done. What are the ones that we need to action first? And what are the ones that we really need to push hard for? And then we've ensured that implementation and translation are key. And so the project funding that we have is firstly to design the model of care, and then to actually start to implement some of those components of the model into systems and to trial and evaluate that. We made sure that we had funding within the budget, the project, to be able to do that. But we also have a long-term vision that it goes beyond the life of this 2-year project, to ensure that, you know, we won't be able to meet all the needs that come out of the model. There are going to be big systems things that we need to address, and we need to make sure that we've got long-term sight so that we don't just drop the ball. In terms of inclusive partnerships, we're very much focused on two-way learning, bringing together women with personal and professional experience to share that. And we've developed a toolbox, which we've informed through an environmental scan of what's happening out there, so that when women have questions, we can go, this is what we know, and bringing the evidence to the women to make decisions about. We've got a really strong focus on determining recognition. Women will determine the recognition and ongoing involvement that they would like to have. And the Aboriginal Women's Governance Group are overseeing the development and our compliance to a protocol around intellectual property, publication and commercialisation. And the last principle is around transparency and evaluation. We will be doing evaluation of our co-design process and to shape the evaluation of the implementation. We really strongly encourage people to explore Literature Institute's tools and trainings around culturally safe evaluation, which actually has a component in there around co-design of evaluation. And the things that we, as Karrina and I were preparing for this, we were really reflecting on and thinking about, these are the challenges that we have in co-design. Firstly, funding often restricts true co-design. It's really hard to write a grant with co-design. So as you saw from that early sort of 4-stage process, we had to say, look, we think some resources or tools will be part of what is a priority for women. So we'll plan to do that, but acknowledging that if that isn't something that comes through the model of care, then we won't do it. But writing that into a grant is really difficult. Ethics and governance processes take an exceedingly long time, and the process of co-design requires ethics, and then at the moment you're having to return to ethics to progress whatever happens. And so it's taking a exceedingly long time to get through ethics and through governance processes. And I don't feel like those systems are quite ready for co-design or well designed for co-design. And then it's important to think about how you're going to fund the next steps after you've got whatever you've co-designed. It's really important to have everyone around the table at the start, and those principles really highlight that. We need the resources and time to build the resources and capabilities of communities and of organisations to be able to participate in this. And recognising that is really important, and ensuring that we're respectful in the way that we recognise that is important. Capacity is a big issue. And then finally, and I think Tina touched on this as well, but what if co-design identifies big picture change? We know that the issues that are driving inequities for Aboriginal and Torres Strait Islander communities in terms of health are underlying systemic issues. And if we want to change those things, then the things that are going to be identified are going to be big picture systems things. And we need to think about how can we ensure that we're responding and delivering on the things that have been co-designed by communities when they're such big picture things. And I think we need to be really careful and considerate in the way that we think about translation and ongoing commitment in this space. I know that we've been yabbing on a bit, but Karrina and I just had this amazing experience. We were funded by the Stroke Foundation to go and do a study tour in Aotearoa, New Zealand, and work with the team who are doing Mahitahi, which is the Maori, what Maori would call co-design, but it's Maori, right? And it's grounded in kaupapa Maori methodology. And some of the things that really stood out for us was how organic the process of co-design is. And that, again, it was founded on relationships and ensuring that there was appropriate and dedicated time within the co-design to develop those relationships before you started having the conversations around this is what we're designing or this is what we need to change. So it was fundamentally grounded in relationship. And we'd strongly recommend people to read that paper led by Anna Rolliston. Karrina, did you have any comment on that? No. And we have an amazing project team and investigator team. So I just wanted to pop that up and share that as part of it and acknowledge that team. I've also realised as I've been talking that we haven't acknowledged the funders of this project. So this is a MRFF funded project, which is funded through MTP Connect. So we're very fortunate to receive that funding through them. Thanks.
Thanks, Kat and Karrina. That was such an interesting presentation, and thank you, Tina, as well. So many good points and so many good resources that you've mentioned throughout your presentation. And just, towards the end of your presentation, when you were talking about ethics, how difficult it is to describe co-design in a grant application, and then when applying for ethics, that's I think just for any project in co-design, because you actually don't know what's going to come out of your co-design project until you actually go through it, and then it might be different to what you propose initially. So I completely understand that. And if you identify big picture solutions, then how will you remain accountable to the people that you engaged throughout this study? Like, how will you be accountable to addressing those big picture priorities? And I just saw that there's two people who asked some very interesting questions. So the first ones are directed to Tina. So we've got about 5 minutes for questions. So the first questions are for Tina around how long did you allow for the co-design process? And then any tips or traps for the unwary?
It's a good question. So with this project, we allowed for the co-design as well as, like we talked about, the sort of implementation process. But full disclosure, we are going to have to apply for an extension on this project to finish our last little bit. Not so much actually held up by the co-design, though, to be fair. That was more other things like COVID and other things that went on during this grant cycle. But having said that, when you allow for, Kat has alluded to this in those sort of tips, I think they were all really good just at the end of her presentation around, you have to know it will take longer than if you don't do it. So like that's you have to plan for that. And that, I don't think that should be a deterrent to doing it, because, you have to stay true to doing things the right way. And so, if you do research in Aboriginal and Torres Strait Islander health and wellbeing in particular, you have to know that it's not going to be simple or easy that maybe if you did it in other population areas. It's like the challenges are great, but they're there for a reason. So, ethics is there to keep people safe and to prevent researchers from, not doing research the right way. Is it long? Does it add time? Absolutely. Do you have to go back multiple times with ethics modifications? Yes. And so, putting those into your timeline is really important. And then like Kat said, building that, if you're going for a grant, building that into your proposal. And that can be tricky and maybe not always attractive for competitive grant cycles, but like that we show that we do get projects funded which are really based on co-design. So it's it's really important. And Aboriginal and Torres Strait Islander peer reviewers who are assessing grants will still look favorably upon these things when they're present. So I don't think they're things to put you off doing projects with co-design. And so I just think I don't know how to give a timeline of how long to allow for co-design, because it probably depends on the project, and it depends on maybe what you're trying to produce and how in depth that is, because you could probably still have a genuine co-design process. Like Kat said, Maori talk about the importance of relationship. It's the same with mob. You need to spend time building the relationship, then you need to spend time doing the actual co-design, and then so on. And you might have to compress that for a particular project within a short period of time, and that's that's okay, but it is about engaging in all the important steps. And so maybe that's compressed into a short time if feasible, or for large projects like ours, the Taking Calendula in the North, that's over 5 years of, really working and commitment. So I think it's variable about how long it will take, but more important to plan for those things like, okay, well, it takes time to build relationships and find all the right people. It'll take time to, do ethics and modifications. And so just factoring those in. And I guess pitfalls for the, lessons or things to learn is probably that around, planning accordingly. and being flexible so that if things don't go as planned, you know, there's a backup plan, or there's still a, you know, there's still approaches, because obviously when you're working with people, the unexpected happens. And so, you know, building those type of things in would be my biggest tip, probably.
Thanks, Tina. Great answer. And then I guess to any of you, if you're working on a project that's not exclusively based on Aboriginal community requirements only, but it's for the broader community as a whole, are there any tips that you could share on how to effectively engage Aboriginal community members in the co-design process? That was a question from someone in the audience.
I mean, I've got a suggestion, and then Kat, if you want to, or Karrina, if you want to add anything. I was thinking, you know, obviously there's times where you might have a broader project and you think it's important to talk to Aboriginal and Torres Strait Islander people as part of that and involve them in the co-design process. And so when it's not an Aboriginal specific project, you know, there's things that we have like Aboriginal Torres Strait Islander governance and all of those things. It's probably about being strategic and finding the connection points. So I mean, maybe if you're in a health service or in sort of a health kind of delivery context, there might be existing governance structures there, or programs or community groups or key stakeholders from within that service who might be able to either support you or engage in that process. So I think it's more, you know, just being strategic about talking to the right people. Like you said, if it's not entirely an Aboriginal and Torres Strait Islander focused topic, but you want to engage the community, there's, you know, I think it's just about knowing who is in your area, making some connections and chatting to them to get some advice as well.
I would just add to that in terms of, thanks, Tina, in terms of approaching like Aboriginal peak bodies in terms of representation. Because that's the, you know, the project space that I've been in for quite a long period of time now, in terms of other projects which might have impacted in terms of a broader. So we interviewed both non-Aboriginal and Aboriginal staff, for example, but ensuring those themes are, you know, that we actually separated findings into, and then brought the Aboriginal and non-Aboriginal voices back to the project and governance team in terms of next steps. So we tended to involve Aboriginal leaders from services, policy, peak organisations, and, you know, and ensuring that they're part of our governance.
Thanks, Karrina. Got any comments?
Sorry, yeah, the only other thing I'd add to that is consider specifically what you're co-designing and what you're wanting to get out of it. And then think about the power dynamics. So for example, you know, you wouldn't want to necessarily go and do a co-design of a program and invite one Aboriginal and Torres Strait Islander person into a largely white space, because that would not be a safe space. So you may need to create a dedicated space for specific engagement with Aboriginal and Torres Strait Islander people and communities and services. You may want to have a dedicated stream of your co-design. So for example, you know, if you were designing a cardiac rehabilitation program or something, you know, you might have a co-design process that's going with, you know, Western Caucasian community, and then have a co-design process with Aboriginal and Torres Strait Islander communities. You might have another one for culturally and linguistically diverse communities, and then bring those together when they've developed their relationships within their groups, concluded what is really important to them, and then bring the groups together and go, okay, these are the things that we saw similarly or saw differently, and how can we create a program that is responding to everyone's needs. But I think really carefully thinking about that power dynamic and ensuring a safe space is first and foremost.
Yeah, well said. Thanks, Kat. And on that note, I think I will close our meeting for today. I'd like to thank our speakers who did a fantastic job today. So Tina, Karrina, and Kat, thank you so much for your presentations. This webinar will now live on the HTSA website. So if anyone wants to share this talk with some of your colleagues, please feel free to visit our website and find the webinar on our website. I'm just going to share my screen one last time to introduce next week's webinar, which will be our last one of the series. We'll have some closing remarks from Keith Stockman and Narelle Hinckley. They will be sharing some examples of co-design in health services and sharing some closing remarks around what co-design is not. So I'd like to thank everyone for coming to this I guess installment of the Spotlight series on co-design. It was a fantastic talk, and I'd like to thank the speakers again.